Hello, my name is Alex Louie, and I'm a radiation oncologist from Sunnybrook in Toronto, Canada. And I'm pleased to assume the role as co-chair of the ISRS Guidelines Committee. I will be leading the new extracranial guidelines, and Dr. Rupesh Kotecha will be building on the existing CNS guidelines. The lung was one of the first anatomic regions wherein extracranial stereotactic radiotherapy was ever first utilized. And so it's very fitting that our first two extracranial guidelines have been accepted for publication in the Lung Cancer Journal. The first, stereotactic radiotherapy for lung oligometastases, was led by Drs. Mayinger and Guckenberger. In this systematic review and meta-analysis, local control at 1 year was 90%. And because of the rich literature and available long-term follow-up, we're able to estimate that at 5 years, local control was nearly 80%. Notably, the risk of toxicity was exceptionally low. For serious acute toxicity, 0.5%, and for late serious toxicity, less than 2%. Part of the aim of these and other upcoming guidelines from the ISRS are to provide practical guidance to our members. And so to that end, in this particular guideline, there are 21 statements that cover the areas of staging, patient selection, treatment, and follow-up recommendations. The second guideline is on the use of stereotactic radiotherapy for ultrasensual lung tumors. And this was led by Drs. Yan, Slotman, and myself. As a side note, Dr. Yan was actually recently a trainee of ours, having completed a fellowship with our group. And Dr. Slotman was actually one of my own fellowship supervisors about a decade ago. And so this guideline really represents what the ISRS stands for, which is mentorship that's really come full circle, at least for myself, in this particular publication. The role of SBRT for ultrasensual lung tumors is a very hot topic because of notable risk of treatment-related death. In this particular study, we found that that risk is about 4%. And this highlights the challenge of when the tumor is right next to a major organ at risk, like the airway or the esophagus, that we have the competing priorities of trying to optimize local control, but at the same time, trying to minimize serious toxicity. In this particular systematic review and meta-analysis, we included both primary tumors as well as metastases, and a variety of recipes from a dose fractionation point of view were employed. Most commonly 50 gray in 5 fractions, 60 gray in 8 fractions, and 60 gray in 12 fractions. Local control, much like in the first guideline, was very good, 90% at 1 year. But because of the limited amount of follow-up in this relatively newer indication, we were not able to estimate long-term local control robustly. The risk of high-grade toxicity was 6%, and risk factors for serious toxicity that led to death included the use of anticoagulation, the presence of interstitial lung disease, the presence of endobronchial tumors, and the combined or recent use of targeted therapy. Other studies that are coming soon, like Sunset, are to be reported at ASTRO this year, and this will add to the evolving literature on what the optimal therapeutic ratio is for stereotactic radiotherapy when considering an ultracentral lung target. And so with that, I'd like to thank you for your attention, and please stay tuned for other practical ISRS guidelines that are coming soon.